going through my clinical rotations helped me see which specialty I would actually be interested in, and I'm pretty sure I know what specialty I'm going to go into. Hi YouTube, welcome back to my channel, Madam Winnell. I know it's been a couple of months since the last time I checked in with you guys because life has just been so busy, so crazy, but I am back. I am currently in quarantine, social distancing in New York City. I'm actually not currently in rotations as all of the medical students at my school and most medical students all over the US have been removed from their clinical rotations due to the current COVID-19 coronavirus pandemic that's going around. And that decision was made so that hospitals could prioritize their patients and the essential staff. And yeah, you may be thinking like, oh, we're medical students, we are essential, but technically, since we are still training and attendings are supposed to be teaching us, that would actually interfere with the efficiency of treating these COVID-19 patients, as we see how quickly and drastically it has overwhelmed our hospital systems. So in the meantime, I'm actually doing online clinical modules. So anyway, since the last time we spoke and I updated you about passing my step 1 exam and how happy I was, there's been a lot that's been going on. So since then, I started my clinical rotations. I also took my second board exam, which is a clinical board exam where you have about like 8 patients. They're standardized patients, so they're actors. And you go from room to room. You get 14 minutes to assess the patient, figure out the diagnosis, tell the patient your treatment plan, and then you have 9 minutes to go and write your SOAP note about the encounter. So I took that in February. I'm still waiting for the results of that, so keep me in your prayers. Fingers crossed. Yeah, so that was that. I was going into clinical rotations just pretty open, but I was kind of torn between medicine and surgery. Going through my clinical rotations helped me see which specialty I would actually be interested in, and I'm pretty sure I know what specialty I'm going to go into, but I will share that in another video. So I'm going to go through each rotation that I rotated in and completed, and I'll tell you how to prepare for each, the schedule, the good and the bad, and all that good stuff. So before starting rotations, what's most important is that you go there with an open mind. You may have your eyes set on, oh, I'm going to be a plastic surgeon or whatever it may be. And when let's say you start psychiatry, because you're not interested in psychiatry, it's not good for you to go there and just, say like, well, I'm going to go into plastic surgery. You should just come in there like a sponge and just absorb as much as you can, because there's so much to learn and everything's really new to you, and you never know, you could change your mind about a lot of things. So here's some things that you need to prepare yourself for clinical rotations. So first, it's important to know that you will be rotating in the hospital, but you will have an exam each month after that rotation ends. So if you're going to rotate in internal medicine, at the end of the 8 weeks, you're going to have an exam in internal medicine. So it's clinical experience that you need to know, and then there's also a written component. So the exams don't stop in 3rd year, unfortunately. But how I prepared was UWorld, which is a question bank that most medical students already have. We're familiar with it because we used it for step 1. Then ComBank, because I go to a DO school, and those have like specialty specific questions. And UWorld has questions for everything, and so does ComBank. But UWorld, I would say, is the gold standard for your COMAT or shelf exams. UWorld is honestly the best. It has the best explanations. It has the best graphics and algorithm photos and all that stuff. So UWorld. Also going to need to use Online MedEd, which is a series of free videos that goes over so many clinical concepts from cardiology, psychiatry, OBGYN, and I love videos because I feel like while it might not be like active learning and a little passive, but you can kind of make it an active learning tool to use. And he's really good with explaining each step-by-step process, because that's what step 2 and level 2 is all about. It's about what's the best next step, what's the best treatment, what's the best diagnostic modality, or whatever it is. So online med is really good for that. And then as far as going on your rotations, you're going to need your white coat, of course, your stethoscope, and I have some books that actually helped me, like this primary care book, which is created by Massachusetts General Hospital, one of Harvard's hospitals. And it has like all these algorithms and different treatments that you can use. So it's really handy for being in the clinic. And then this one is another one of their books. I got these all on Amazon. I think they were all under $20. Pocket medicine. So this is really good for the hospital wards, and has everything from like pancreatic tumors and EKGs and cardiac ACLS algorithms for cardiac arrest, and when there's codes and all that crazy stuff that can go wrong in the hospital. And this is the Maxwell Pocket Quick Medical Reference, which is really, really great. I actually just got it because a doctor recommended it for me. And this is basically what like everybody should have. You can use this for literally any rotation. So the Maxwell Medical Reference, it has a bunch of EKG rhythms. It has EKG rhythms. Oh yeah, EKG rhythms, I got that right. It also has like BLS, the axes for looking at the EKGs, and ACLS when there's like a code. There's ACLS for strokes. It has all of that information there. It has normal lab values for like all the electrolytes, normal lab values for red blood cells, for everything that you would see in the computer in the hospital. It's all here. It has a stroke scale. It even has an HPI, and so that you can kind of guide your notes when you're writing your notes in the hospital. And it even has a guide for doing an on-service note, progress note, discharge note, admit, transfers. So this is really good. It has dermatomes. It's really good. The mental status exam, and even the Snellen chart on the back. I mean, this is really definitely necessary. Okay, so I didn't want to make this video too long because I don't want to bore you, and I want to get straight to the point. So I'm going to go through each rotation as I went through them. So my first rotation was family medicine, and the schedule of family medicine was about from 8 a.m. to 5 p.m. And I still live in New York City, but most of my rotations were in New Jersey, and New Jersey is really close to New York City. So I would just take the bus. From door to door, it took me about like 30 minutes. I would Uber to the bus station, which is like a 8-minute Uber, and then the bus takes 15 minutes to cross the bridge. So it was a pretty good commute to the hospitals I needed to go to. So anyway, my family medicine rotation was actually half in Jersey, and then I did another half in Harlem. So the schedule was like 9 to 5 p.m. And it's basically like your typical clinic. You're going to see your bread and butter cases like diabetes, high blood pressure, and a lot of it is just like adjusted medications, patient education. Sometimes you have, you do like physicals and sports physicals and stuff like that. So it's all those bread and butter cases. And what I did like about family medicine, especially when I was in Harlem, was in Harlem there's a big African American population, and it was just really nice seeing a lot of patients that looked like me, and I'm sure they liked seeing a future doctor that looks like them also, and they felt like I was someone that they could trust. If a doctor told them to take their medication or started a new medication, when the doctor left, they'd be like, "Girl, is that right? Is he lying to me?" And I'm like, "No, that's right. You should be taking this." And so I would tell them, and it was funny because a lot of them obviously were older, like 50s, 60s, 70s, and they kind of saw me as their grandchild or daughter or whatever, and they would just always look out for me, and they'd be like, "Let me know if any of these people are are treating you badly, because I'll set them straight. I'm like, okay, auntie, okay, auntie. I just liked being in a community that I felt like I can make a difference, because I represent them, and I also had that sense of pride, and they would always tell me how proud they were of me, and it just made me remember like why I'm here and how much work I can really do in my community. But you can honestly make family medicine as diverse and widespread as you want to, because you kind of have free reign. You're treating patients from infancy to them being a senior citizen, technically. So you can make it as fun as you want it to be. Then next was internal medicine. And internal medicine was cool because I worked 1 month with a primary care physician, and then the second month I worked with an infectious disease doctor in the hospital. So that was cool. I was seeing a lot of like pneumonia cases, cellulitis, and the infectious disease doctor, of course, he was showing me, giving me lots of lectures on all the antibiotics and all these new things, and just like kind of refreshing my memory and all that stuff that I kind of stored away during STEP. And the primary care doctor was really good at teaching me how to become really good at the physical exam. He was so thorough, and I would listen to heart sounds and listen to the lungs, and he'd tell me to describe it, and he'd be really like particular down to the T, like, oh, what kind of murmur is that? Is it between S1 or S2? Is that the first heart sound? Do they have a third heart sound? Describe how the lungs sound. Is it dull? Do you hear crepitus or whatever it is? And he was very, very thorough. So I'm very grateful for that experience. But I do feel like being in the hospital is kind of different, because I do feel like from minute to minute or hour to hour, the patient's lab values may change, and then you have to figure out, oh, why is that happening? So there's still that critical thinking component, and that's why I did enjoy internal medicine. So after internal medicine was surgery, and surgery was cool. So my first month was general surgery, and I got to see a lot of colorectal cancer cases, the bread and butter appendectomies and cholecystectomies, removing the gallbladder, and some vascular surgeries, which I thought were cool. The hours though with surgery, like the last month, was pretty hard. I had to wake up at 4 a.m. in order to get to the hospital by 5:30 a.m. and I would be at the hospital until like 5 p.m. So yeah, it was basically like a 12-hour day, 5 days a week, 60-hour work week, which is a little taste of residency, which is gonna be 80+ hour work week, which I look forward to. Yay! But anyway, so yeah, so surgery was cool. What I liked about surgery was that I had a chance to work with the residents, and it kind of made it seem like you were in residency, and you were like rounding with them, where we'd come to the hospital at 5:30. I would pick a patient to see who was either pre-op or post-op, and I check their surgical wounds, or check their lab values, and see if maybe if they are anemic, or whatever it was that we needed to fix before surgery or after surgery to make sure that they were stable. And then we would present the patient to the team, which was the other medical students and the other residents. What I didn't like in particular about surgery was the atmosphere in the OR. And it wasn't all the time, and it wasn't everybody. There were some attitudes in the OR that just wasn't so nice and so inviting. And a lot of times it would come from like the OR techs or OR nurses, who would kind of yell at you or give you attitude and kind of make you feel unwelcome there. And during those times, I didn't enjoy the OR, and it did kind of turn me away, or just kind of give me it just left a bad taste in my mouth, honestly. And I know that obviously if I'm a doctor, it could be a different experience, but as a student, and I understand that we are like at the bottom of the food chain for now, because we're still learning, we're just like baby doctors. But yeah, just sometimes in the OR just wasn't the best experience, and I would say that was the worst part of surgery. My next rotation was psychiatry, which I absolutely loved. I loved psychiatry. So my psychiatry rotation was really hands-on. We were with residents, so every day we did morning report where one resident would present on a patient that came into the ER, and they would detail the course of their treatment and whatever happened, and then we'd ask them questions, and it was really inclusive of the medical students. I kind of felt like I was a resident too. Also, I had a really good experience with being on like the involuntary units for the patients that are basically in the psychiatric ward, and what most people think about when they think of psych wards. Like on our first day in the involuntary unit, I was a little afraid, or I didn't know how to engage or interact and conduct a psychiatric evaluation, but eventually I did have a resident who kind of walked us through it and explained it to us. So that was pretty cool. I got to talk to a lot of the patients and like hear their insight and hear their stories about why they were involuntarily admitted there, and see some of those patients actually get discharged once they got stabilized. So that was actually cool to see. I think what I loved the most was actually the child and adolescent floor, because it was just crazy to see so many young people who were already depressed as young as 9 years old, even using drugs to kind of numb the pain, as they say. And you see how influential like our culture is, and just social media, and how negatively it can actually impact the psyche of our children. And I think that was actually just like really eye-opening and mind-blowing. But I did feel good in the sense that because I was a little closer to their age, I could kind of understand where they were coming from, and I could actually, give them and kind of like uplift their spirits and give them some motivation, and to look towards the future, because I did feel like the general consensus was that they were misunderstood and their parents just don't understand where they're coming from, and even some of the doctors, because they're of a different generation, they just didn't understand where they were coming from. So I felt like I could actually help them in that way. Next was OBGYN. OBGYN was pretty cool. I saw lots of vaginal deliveries, but I saw even more C-sections. I was assisting in C-sections, holding the bladder blade down so that they could, pull the baby out. You have to hold the bladder blade so that it's not touching the uterus, and so the OBGYNs can like do their thing, then cut the sac open and get the baby. So the best part about OBGYN was, I would say, like the C-sections or the vaginal deliveries when the baby is born, because I don't know, there's like this feeling that comes over you when the baby emerges from the womb or from the transverse C-section incision. I don't know. It's just like, oh, and then just the mom and dads. It was just so nice. Like I felt like I was part of the family, but I just met them. But it was cute. It was really cute. I liked that. I also liked the gyne surgeries. I got to see myomectomy, which was removing fibroids from the uterus. And the one that I was in, we actually removed, I think it was like 18 fibroids. And it was in a patient who had infertility issues. And so in about a year, hopefully, she'll be able to conceive. So that was another gratifying surgery. Lastly was pediatrics. So pediatrics was actually interesting. It was honestly more newborns rather than, like toddlers and teenagers, but a lot of newborns with respiratory issues like croup and RSV, asthma, lots of asthma, teenagers with appendicitis, and going to surgery. We would do the newborn exams as soon as the babies were born, and that was cute, just like looking at all their reflexes, and also examining for jaundice and putting them under the blue light if their bilirubin levels were too high. But the only thing I didn't like about pediatrics is the fact that because children obviously are not adults, so with every medication you have to calculate everything, and I don't like math. So anything that involves calculation and math again just brings back bad memories of my math class. But yeah, besides that, pediatrics was pretty Lastly, I was rotating in emergency medicine. I did a couple of shifts, but eventually they told us that we had to suspend our rotations due to the coronavirus situation. And the ER was cool. You know, I did see a couple of codes, some stroke codes. I saw drug intoxications, and what else? Oh, a miscarriage, which was actually sad. But yeah, so the ER, you know, it's pretty fast paced. People come in, you kind of have to like get to the point and ask the right questions so that you can kind of figure out, does this patient need to be stabilized here in the hospital and admitted, or can we discharge this patient? So it's about being efficient, it's about being quick and coming up with your diagnosis. But yeah, I think I've been talking too much, and I just wanted to update you guys. Since I have all this time now, I don't know when we'll be back on rotations, but in the meantime, keep social distancing, quarantine, Netflix and chill. Because remember, like, this is the first time in our lives where we can actually save the world by staying home and watching TV. So don't mess it up. Do not mess it up. But yeah, I'm about to go because I'm really, really hungry, and I just ordered some burgers and I'm happy. I'm happy. Sorry, I'm becoming delirious. It's this quarantine. I apologize. But yeah, I'm going to see you in my next video. Bye bye.